It's S-shaped, it has a double curve, it's flat laterally, it's circular or tubular in the middle, and then it becomes triangular toward the medial side. It's smallest and weakest at the junction of the middle and distal third, and this is where you'll see the majority of clavicle fractures occur. So anatomically, a pictorial description there to reinforce: flat on the lateral side, tubular in the middle, triangular. If you'll notice the muscle area, trying to demonstrate that there's really not good muscle coverage over that middle portion of the clavicle. Again, that's where most of the fractures occur, and it also creates a situation where there's limited vascularity or blood supply in that area to heal the fractures when they do occur. In terms of the AC joint and its anatomy, it's at the junction of the medial acromion, the distal portion of the clavicle. It has a very thin capsule. There are ligamentous structures there. Those ligaments tend to control the anterior and posterior stability of the AC joint itself. Then you have your CC ligaments from the coracoid to the clavicle, and those control the vertical stability at the AC joint. So the thin capsule is represented there. It doesn't look like my animation is going to pop up, but demonstrate there is a small meniscal type structure within the joint. So with a direct impact from superior on the acromion, since the scapula and the shoulder are suspended from the clavicle, when you drive it inferior, first you begin to injure the capsule and the ligaments around the AC joint. And if the force is great enough, then you begin to damage or tear the CC ligaments from the coracoid to the undersurface of the clavicle, and you get a more dramatic or type 3 AC injury. Enough for the anatomy. Let's talk about clavicle fractures. Something you commonly see in athletic competition. Typical appearance with the proximal fragment elevated. This is caused by the pull of sternocleidomastoid muscles. And then the weight of the shoulder and the scapula tends to depress the distal portion of the clavicle to give it this typical presentation. Most 80 to 85% of the fractures will occur in the middle portion of the clavicle. Distally, only approximately 10%, and medially, less than 5%. Medial clavicle fractures are very rare in athletic competition. You can have sternoclavicular dislocations, but they're rare as well. So 90% of these injuries occur with a fall directly onto the shoulder. They occur at that typical point in the mid portion between the middle and distal third. About 10% occur from direct contact. Occasionally we get one from a direct blow from a helmet. Of course, shoulder pads are supposed to be designed to prevent that. More common in hockey, being struck with a hockey stick. It's predominantly a male type injury with a 70-30 ratio. The force of the body weight itself is adequate to fracture a clavicle. It's all it takes to buckle or break the clavicle in the mid portion. And then the pull of the sternocleidomastoid, the weight of the shoulder, gives you that typical presentation. They come in all types of varieties. Some are non-displaced, some are simple, some are green stick, partially broken, and they extend all the way over into the highly comminuted categories, which will require more aggressive treatment. Evaluation in a clinical setting typically only requires an X-ray. You use an AP projection and then a cephalic tilt to get a better understanding of how much displacement, how much angulation, how much separation there is at the fracture site. In terms of treatment, always be aware with these clavicle fractures, there's also a risk for neurologic or vascular injury or pulmonary injury. Typically, that's only going to occur in really high trauma situations, but you need to be aware of it when you're doing your assessment to take care of the athlete. Nerves live right under the clavicle. The ulnar nerve is the one that's most at risk. That would affect your ring and small finger with numbness in the ulnar side of the hand. Suprascapular nerve, axillary nerve are also at risk. There may also be some rib fractures. If the force is great enough to break the clavicle, there is a chance that there could be concurrent rib fractures. And then the subclavian vessels live right below the clavicle. So in high trauma situations, that's another concern or another risk for more extensive injury. For the majority of clavicle fractures, a simple sling, ice, a figure of 8 brace just to stabilize, reduce pain, help produce a little better alignment is going to be adequate. But there will also be some indications to perform surgery for these fractures. Some of those indications include open fractures where the bone is projected through the skin, or skin compromise. If there's enough tinting of the skin that it may degrade the skin where the skin's going to break down, that becomes a surgical indication. Neurologic or vascular injuries, multi-trauma, greater than 1.5 to 2 centimeters overlap or vertical translation, that can get into a situation that may exceed the body's ability to actually heal the fracture. Comminution's another potential indication. If you already have a non-union or a malunion, it's a surgical indication. And then fractures that fall into that risk of becoming malunions or non-unions. Fixation most typically is performed with plate and screws. There are still some individuals across the country that may use an intramedullary pin type system or a Knowles pin, but I don't see that as often as plate and screws. Typically use titanium type products in this area. The plates themselves now are custom made or semi-custom made, so they fit the contours of the clavicle. You know, in years past, you would have to actually bend the plate to form it to that particular clavicle. Stainless steel is also used. These highly comminuted fractures, like the ones I show in the picture, these are just an indication of fractures that would typically require surgical fixation. Representation of the fixation itself using titanium screws. The lesser fragments, the smaller fragments, are first reapplied to create a distal end and a medial end. Then you put those two major pieces back together, and then it's all stabilized with plate and screw. One of the reasons that we don't fix every one of these with surgery is there's always the risk of surgical complications. Vascular, pulmonary injuries, neurologic injuries. You induce a situation where infection becomes a risk, where treating closed it would not. There's a potential for hardware failure. Painful hardware is always a concern because once all the swelling goes down, these plate and screws are relatively superficial right under the skin in that mid portion. Remember, there's not a good muscle cover in that area. So in really thin people, they usually can palpate it. It can be unsightly, may become tender. We rarely remove the plate unless there's a really strong indication. So very high incidence, 25 to 40% risk of refracture if you fix the fracture with plate and screws and then you subsequently remove it. So we're very reluctant to do that unless it's absolutely indicated. There is a bias that was carried through in the country for years. In my generation, coming through orthopedic surgery, we tried to treat every clavicle fracture without surgery if at all possible, because there were old studies that showed there was a 4-time increased incidence of non-union if you operated on the clavicle than if you just let it heal naturally. I've already pointed out there were exceptions. However, newer data shows that the risk of non-union is actually lower with surgical fixation than if you go ahead and let it heal by natural means. Consequently, many more clavicle fractures are fixed surgically today than they would have been 20, 25 years ago. Just a representation of unsightly or very superficial hardware. In applying the hardware, we try to use techniques to avoid these situations. The bottom picture shows where a Knowles pin is trying to work its way out through the skin. Medial clavicle, already mentioned, very rare in athletics. Dislocations occur, they're rare as well. In your younger athletes, your junior high athletes, they can suffer injuries in that area if they still have active growth plates, and they can separate a growth plate and create a very painful injury. However, most of these are still non-surgical situations. There's a special group of fractures in the clavicle, just a couple of comments, particularly the type 2A and 2B. 2A being a fracture that occurs proximal to the CC ligaments, just adjacent to the CC ligaments, out in that distal third, or 2Bs, which occur between the two ligaments. These are very high risk for non-union, 20 to 30% risk, and so these are typically fixed with surgery, surgical fixation at the outset. Just picture representation of a 2A in the top picture with a star and a 2B down below. You notice how far out distal on the clavicle these occur. And an X-ray representation of a 2A fracture. So what is a non-union? It's classified as no radiographic evidence of healing within 4 months post-injury. Many of these occur with those special 2A and 2Bs if they're not treated appropriately from the outset, but it can also occur in midshaft fractures. Remember, there's not as good a blood supply in that area. It's not covered with muscle. It can happen. Risk boiled down to the amount of energy at the time of injury, which leads to higher comminution, which implies more soft tissue stripping at the time of injury. Less blood supply, less ability to heal the fracture. Displacement beyond 2 centimeters, I mentioned earlier. This begins to get into an area that the body finds it very difficult to form enough callus to solidly fix the fracture itself. In the majority of fractures that are highly displaced or comminuted, when I operate on these, I typically find soft tissue interposition. So that means that the fracture is displaced when you look at the x-ray, so you decide to operate, you go in, you find that one of these fragments is actually buried in muscle, and there's no way those two pieces are going to ever come back together. And the body has some healing capacity, but if there's too much separation, it's just never going to heal because the two pieces are just too far apart, buried in the muscle. Older people, higher risk. Females, higher risk. Smokers, higher risk to develop non-unions. So to treat a non-union, you have to reduce it. Often requires bone grafting to enhance healing, and it requires rigid internal fixation to gain union. Just a representation of fixation of a non-union. You'll notice an interposition graft in the mid portion under the plate, which looks like a piece of cadaver graft or it's iliac crest graft that's been placed there to fill the gap from the non-union to gain solid union. All right, let's change gears and go to the AC joint. AC joint injuries occur with a direct blow or fall directly on top of the acromion to begin to disrupt those ligamentous structures that I mentioned in the anatomy section. The AC joint can also be injured by indirect force, and usually these are more chronic injuries. These occur in weightlifters who try to lift massive loads. The minimal amount of motion that occurs at the AC joint actually can stress those ligaments enough to develop a chronic use injury within the ligaments themselves. The AC joint injuries encompass greater than 50% of the shoulder injuries that we see in sports medicine. Most of them occur in people under the age of 30, and again, the guys outpace the girls by a significant margin for this injury. There are 6 different types. Rockwood made a modification of the Ullman and Tossi classification. I'm going to try to simplify that a little bit. This is the verbal description to classify the 6 different types of AC separations. But I think there's a little easier way to think about it. In the lower grade injuries, the capsule and the ligaments at the AC joint itself are either partially torn or completely torn. So partially torn would be a type 1, no displacement. At the site of injury, everything looks maybe a little swollen, but there's no bump on top. If the capsule and the ligaments are completely torn, you become a type 2 AC sprain, and then it looks like the clavicle sticking up a little bit, about 50%. In reality, the shoulder and the scapula are actually hanging down. It's a knockdown shoulder. But we all describe it as the clavicle looks like it's sticking up. If the force is great enough to go ahead and tear those CC ligaments that come off of the coracoid to the undersurface of the clavicle, then you develop a type 3 AC separation, and there will be 100% displacement of the clavicle on X-ray relative to the acromion. I think the only reason that these classifications are pertinent, you can predict the healing capacity, the return to play, based on which type of AC sprain has occurred. To get into the more complex types, 4, 5, and 6, those are depicted on the bottom row there. These are really high trauma, high stress type injuries. So in a type 4, the clavicle is actually driven posterior compared to the AC joint. It's displaced posteriorly and fixed there. In a type 5, it's like a monster type 3, because now it appears the clavicle is elevated 100 to 300% relative to the acromion. And the really weird bird is the type 6, where the clavicle becomes trapped beneath the coracoid. I've never seen one of these. I don't want to ever see one of these, but that would be a really high trauma injury. So I just described the different types. There's not a controversy, but throughout my career in orthopedics, there's been a discussion about how to treat type 3 AC sprains. Every meeting I go to this day, it's always mentioned, it's discussed. But the majority of orthopedists across the country treat type 3 AC sprains non-surgically. The outcomes tend to be good. There's a cosmetic deformity with the bump, but functionally, the people tend to recover and do fine. If you operate on them acutely, you trade a scar for the bump, literally. Now, if the patient remains symptomatic long-term, they've had adequate healing time, 2 months, 3 months, 4 months, and they're symptomatic, it can still be surgically repaired. And the operation performed at that time is essentially the same operation that would be performed within the first 2 weeks of injury. So they haven't really lost anything, but it is really pretty rare to have to operate on the type 3. One exception might be a high-performance thrower, professional level athlete. Sometimes they'll go ahead and fix them if that's their dominant arm. Whoops, wrong button. He warned me about that. So I've already described a type 1, just a pictorial reminder. Type 1 occurs partial injury at the capsule. Type 2 is a complete tear at the capsule, and a type 3 also involves the CC ligaments. For a type 1, I would typically expect an athlete to be able to return to play in 1 to 2 weeks. They're treated with a sling ice, early rehab. When they can tolerate the pain, they can play. If you wait till a type 1 is totally pain-free, you may be waiting anywhere from 3 months to a year. So there's a lot of lingering symptoms with these, but it's a safe injury, and we clear people to play when they have full strength and they can tolerate a hit. In a type 2, they're treated essentially the same way, but you probably anticipate return to play in 2 weeks to 6 weeks, depending on symptoms. There is some risk to develop arthritis long-term after a type 1 or a type 2 AC sprain, but that's not a short-term consideration. Type 3 is a more violent injury. May take anywhere from 4 weeks to 8 weeks for them to become pain-free and to regain all of their strength. However, long-term, the type 3s tend to do quite well. They become asymptomatic for a lifetime in the majority of cases, and since the clavicle is 100% displaced, they are not at risk to develop arthritis from that injury long-term. Type 3 surgery has kind of gone through some evolution, but essentially you have to reduce the clavicle back so it's symmetric with the acromion, and then stabilize it there either with sutures or a screw. Sometimes the coracoacromial ligament is detached from the acromion and put back into the end of the clavicle as part of that operation. That's not done quite as much as it used to be, and that's called a modified Weaver-Dunn procedure, and this is just some cartoons to show how it's done. Most typically these days we use a device similar to this one. Describe it as having doggy bones. So if you look real close, you'll see there's a little metal tab on the top of the clavicle, metal tab under the coracoid, and the sutures are placed through the clavicle, through the coracoid. They're tightened in place. And then you would reinforce this with soft tissue repairs out toward the more distal end of the clavicle to reinforce the soft tissues to get the healing. But these tend to be very stable constructs. Already mentioned the higher level ones. These are very extreme trauma cases. Probably not going to encounter those in athletic competition. Another picture just again to show the bad ones, the 4 being posteriorly displaced, extreme elevation of the clavicle for a type 5, and then clavicle traps for a type 6. So type 1, quick recovery, symptoms can extend over months. Type 2 takes a little longer, but the type 2s actually have less nuisance symptoms long-term, in my opinion, although some of the literature indicates that they can have nuisance symptoms for 6 months to 5 years in 50% of the cases. In type 3, they tend to do quite well, and most of them have good outcomes, greater than 90% of the time, without any surgical intervention. Osteolysis. Has anybody in the crowd ever had an athlete diagnosed with osteolysis of the distal clavicle? Okay. Some of them, okay. So this is an interesting phenomenon. Science doesn't know why this occurs. In essence, it's disruption of blood supply to the distal end of the clavicle. And it tends to occur just spontaneously in the lower grade AC injuries, like a type 1. Or I see it more frequently in weightlifters who develop this condition and begin to have extremely severe pain. So in a scenario where you had a grade 1 injury in your athlete and they're improving, and then about 2 weeks, 3 weeks, suddenly they come to you and they tell you, hey, my pain's getting worse. I've got a lot of pain now. I've had no new hits, no new injury. Need to evaluate them for osteolysis. Characteristically on x-ray, we look for areas where it looks like the clavicle is dissolving. You see little irregular areas. I've seen extreme cases where there's loss of 1 centimeter to 2 centimeters. I have a hockey player that I recall. And it just looks like it's dissolving and going away. Most will spontaneously resolve. The duration of time is not predictable, and it can extend for months, up to 12 to 18 months in some cases. They are generally treated with conservative management, just support and observation. If it extends beyond a reasonable amount of time, then cortisone injections can be used, And if it's a chronic case that's just unrelenting, then the surgical treatment is to go in and excise the distal clavicle to relieve the pain. And I think it's more like the red hot poker theory of treating shoulder dislocations in the old days. What you're doing is creating surgical trauma in that area and enhances revascularization, and that's what helps relieve their symptoms. Knock on wood, I've never had to operate on one, but that is the ultimate treatment if it never resolves. Brachial plexus injuries. So these are stingers. They're nerve injuries. Every athletic trainer is going to encounter stingers in multiple sports, usually stretch injuries in the neck, but not all stingers are created equal. Typically for your garden variety stinger, as soon as that player regains strength, pain goes away, they can be cleared back in. Same day, continue. The things you have to watch out for are more dense injuries, particularly to the suprascapular nerve, which you can test with external rotation of the arm, or the axillary nerve with abduction of the arm. Some of those injuries can be extremely dense in nature and may take weeks to months to resolve. But the player's not safe to play until they regain full strength. Most of them will. They don't always heal as fast as you want them to, but they should heal. But if they get a second hit, they may, in fact, develop a permanent deficit with that nerve group with permanent weakness. And that's why we don't let them play till they get all their strength back. All right, I'm going to change gears again and talk about shoulder dislocations and labral injuries. As you can see by these little cartoons, people have been dislocating their shoulders since the dawn of man. Yeah, it's the most dislocated joint in the body. Anatomically, the glenoid, the cup of the shoulder joint, I think of it like a golf tee. The humeral head is much larger than the cup, and that's why the range of motion is so great. But that also makes it susceptible to instability from the injuries because it's not encased in a cup and ball type joint. So there are two categories of restraints relative to the shoulder. One group is called static restraints, and that would include the labrum that attaches to the glenoid circumferentially, which is connected to the capsule. And within the capsule, there are thickenings which create ligaments to resist dislocation of the shoulder, both anterior and posterior. The most important being the inferior glenohumeral ligament, depicted in the picture on the right at the inferior anterior aspect of the shoulder joint. Then you have dynamic stabilizers that try to restrain the head. You can think of these like check reins. So whatever position you put your shoulder in, there are muscles that are balancing and counterbalancing and trying to keep that humeral head centered directly in the glenoid. Primary for these would be your rotator cuff muscles, subscapularis, supraspinatus, infraspinatus, and teres minor. These are the muscles that need to be rehabilitated when somebody has had a shoulder dislocation to help restore the stability to the shoulder. So those are the dynamic stabilizers. So stability depends on the restraints. You have static stabilizers, labrum, capsule, ligaments, and you have dynamic stabilizers, which are your rotator cuff and some of the other larger muscles about the shoulder girdle. The static restraints can be damaged. They can be torn or damaged, and they may require repair. Dynamic restraints can be rehabilitated, and they both have to be treated together. If the static restraints are genetically lax, that creates a situation called MDI, which is multidirectional instability. A person who can volitionally dislocate their own shoulder, they pop out the bottom, they pop out the back, they're double jointed, they're loose jointed. MDI is the term for the shoulder, multidirectional instability. So some definitions. A dislocation means that the humeral head has come completely out of the joint. Sometimes they'll relocate. You can have a complete dislocation. It didn't get stuck in that position, but a dislocation, the heads come all the way out. When the head comes all the way out, there's a very high risk with traumatic dislocations for injuries to the static stabilizers, the labrum, and concurrently then laxity into the capsule and the ligaments. A subluxation is more of a stretch injury. So the head tried to come out. It came out part way. It stretched those static stabilizers. But it will probably recover without surgical intervention unless there was a concurrent injury to the labrum or the static stabilizer. But subluxation, part way out. A Bankart lesion. That's the term used for an anterior-inferior labral tear. So in the classic, the labrum has been detached from the glenoid, from the cup. It's actually torn away. And when that happens, it loosens the rest of the capsule and the ligaments in the front of the shoulder, and it makes it easier for that head to come out again. On the right, the cleavage you see in the middle, that's detachment of a labrum from the anterior glenoid. There are also bony Bankart lesions, where at the time of injury, the anterior edge of the glenoid was fractured. There's a break through the bone. Or multiple dislocators begin to hammer away at the anterior edge, and they can cause bony deficits anteriorly on the glenoid surface. A Hill-Sachs lesion. This is a dent in the posterior aspect of the head. So when the humeral head comes out and is trapped on the edge of the glenoid, the force of that entrapment can create a depression in the back of the head. Multiple dislocators, those lesions become larger over time, and they can become so large that when you move your shoulder, it levers itself onto the edge and it redislocates the shoulder. So it can contribute to ongoing instability. Slap lesion. A slap lesion is a superior labral anterior-posterior lesion. These can occur from trauma, or they occur in throwers from cocking and accelerating the ball. And in the athletic population, the younger population, 35 and under, they can become a surgical problem. A Hagel lesion, just in case you ever hear it. These are relatively rare. But in this situation, with a dislocation or trauma to the shoulder, instead of the capsule and the labrum tearing at the glenoid, at the cup side, where they attach to the humerus, has become detached from the humerus. And it can create instability, and more typically, instead of ongoing instability, it creates recurrent pain with shoulder use because it's detached from the humerus on the humeral side. So the provocative position for the shoulder, most know it's up here and out, opposite for posterior shoulder. People typically dislocate their shoulders, injure the labrum and so forth with athletic activities in all different types and modes. Some people find social activities where they can dislocate their shoulders as well. Some of these can be really dramatic. Fortunately, I've never had to treat one like this. And some people tolerate their first dislocation or their second dislocation. They really don't want to go in and have surgery. But if you're unlucky like this young guy and your shoulder begins to dislocate while you're sleeping, usually these people will start to come in and ask to be treated medically, have their shoulder fixed. So these are interesting pictures. He's laying there asleep. I don't think his buddies are very nice to just take the pictures, but you can see in the top right, you can see the humeral head extending anterior to the glenoid. And then in that side view, you can see a sulcus sign. See the acromion, you see that kind of dead space. That means the head's not there. It's out of the socket. And then he wakes up and asks them to help him get an appointment to go get that thing fixed. In terms of reducing shoulder dislocations, your best shot is immediately, before the guarding spasm occurs. Best method, I still think, is just gentle traction, internal, external rotation, and just ranging the shoulder. And if they're not already guarding and doubling up on you, you should be able to get it in. Be sure and check for neurologic symptoms before you reduce it. Just ask them to move all their fingers, their hand, move their wrist up and down, rub them on the shoulder, make sure they don't have any numbness. Because you want to be able to document any neurologic injury that occurred with the trauma, and then reassess them after you relocate their shoulder. A lot of times, even if they have some numbness in their hand, it'll go away once they're reduced. The picture just shows a Stimson maneuver. I don't know if that's taught in your curriculums and so forth, but it can be effective, where you lay somebody prone, you have them hold on to something that weighs about 5 pounds, and if they relax enough, you can relocate the shoulder in that method. It's not traumatic at all. So for first-time dislocators, this ends up being a discussion that comes up quite a bit in the clinic in these situations. Initially, you want to immobilize in neutral or slight external rotation. The duration of immobilization has tended to change over time. It used to be 3 weeks. You hold them 3 weeks, nothing sooner. It's kind of gotten back to about 2 weeks. But what you're trying to do is give any of those static restraints an opportunity to start to heal and try to avoid creating a surgical situation. You progress to rehabilitation. You want to strengthen the dynamic stabilizers, and they can be returned to play once they have full strength and they're pain-free. The statistics show that for people under the age of 30, if they suffer a traumatic dislocation, 50 to 70% risk of re-dislocation. That's been true for years, and that's still the statistic. The only difference is we used to say 21, and now at the conferences they say even people up to age 30. The statistic is not the same for people that are 40 and 45. Those people tend to tear their rotator cuff at the same time that they dislocate, but they don't tend to be recurrent dislocators. If they're symptomatic from pain, not necessarily instability, sometimes they require surgery as well. So 87% of first-time dislocators are able to return to play. If they have a large labral tear and they remain symptomatic and they're not pain-free, then they may not return, but they do. And about 50% of the time, those people will opt to go ahead and have their shoulder repaired in the off-season, so they're ready to go the next season and don't take a chance on that second dislocation. Anyone who dislocates a second time should be held out of play, and they're not cleared until they get their shoulder fixed. It's not that they can't rehabilitate and become functional again. These repetitive dislocations can doom these athletes to develop osteoarthritis of their shoulder long term as adults, and we don't want to tear up their shoulder joints. Subluxation, easy treatment, immobilize temporarily, rehabilitate, return to play. If they remain symptomatic, you need to have these folks evaluated as well, because even though they didn't have a full dislocation, they may have torn their labrum and they may remain symptomatic and they may need a little more aggressive treatment. And then try to identify these MDIs, because the MDIs are people we don't want to operate on. We want to rehab. You can tighten them up, but they're going to go out and loosen it up again. So they're best treated with rehab. So the recurrent instability or dislocations occur because of damage to those static restraints. Or it can also be coupled with insufficient rehab of the dynamic stabilizers. This is where the surgeon starts to step in and try to help repair the problem. So you can see the dislocation at the top. You can see the residual damage in the second picture for the labrum and capsule. It's now lax, and it has a Bankart-type lesion in the front. Majority of these are repaired arthroscopically today. The outcomes tend to be 90% success, and except in rare situations or failures of initial stabilization, the open procedures are not performed as often. There's been some debate about contact athletes, but today I would say across the country the majority of these are performed arthroscopically. There are some exceptions, and I'm going to cover those as we move along, particularly with the bony defects. So just to represent these, picture on the left, there's absence of the labrum in the front. You can see a step off, and then if you put the camera in the front and look at it, where the red is in the cleavage, that's the labrum pushed off from the glenoid surface. The rotator cuff is checked for concurrent injury. There's a small Bankart lesion on the back of that humeral head, but that's not very dramatic. And the bicep tendon is checked. Just a little better picture once the labrum's been cleaned up. It's been mobilized. Now the bony surface has been made raw or bare so that blood supply can get to the labrum and capsule after the repair. Suture anchors are then inserted into the bone, and the sutures have to be sequentially passed through the labrum and capsule to reestablish that anterior stability with the inferior glenohumeral ligament. This is what it looks like after they've been applied. You'll notice the position of the humeral head. It's not, you can't lift it up very much now. When I perform these surgeries, my assistants, when I tie my first knot and first suture, they can actually feel the shoulder pull down if it's tighter, and then it's harder for them to lift it up. And that's the whole goal, is to restabilize the anterior aspect of the shoulder. So my IT guy here, there he is.
A Latarjet procedure is performed for patients who have shoulder instability and have failed arthroscopic surgery to tighten the shoulder, or who have extensive bone loss of the humeral head or glenoid. The socket of the shoulder or glenoid can be damaged by multiple shoulder dislocations. This often results in bone loss of the anterior-inferior portion of the glenoid. To replace this lost bone and prevent future dislocations, the surgeon will cut off a piece of the coracoid.
I'll try and describe what this video shows. It was really just about a minute and a half. That's a normal-looking glenoid, and so it looks kind of like a pear. If you have a reverse pear, so the broad part is at the top and it's narrow at the bottom, or you have bone loss, or you've had repetitive hits, and the inferior portion of that glenoid is deficient, then you can do a soft tissue repair, but you're at risk to fail and have repetitive dislocations.
A graft holder is
so there's a
used
procedure
to
that's called the Latarjet. This video showed it nicely, but you take off the tip of the coracoid, you detach it. You make a cut on the back to make the surface raw, and then it's placed on the anterior aspect of the glenoid and held there with screws so that you increase the surface area so the ball doesn't tend to come back out. It's one of the newer procedures that's being done in the country now for the recurrent dislocators. Posterior. Okay, posterior dislocations are classified as about 2 to 4% relative to the total number of shoulder dislocations. As a sports doc, the percentage is much higher than that. Football players are at 15 times risk for posterior dislocations. Also see it in runners. Any force that drives the shoulder posterior out of the socket can tear the labrum in the back. These often have cartilage injuries on the glenoid surface at the time of injury. And they can be recurrent dislocators as well, where when they try to lift and do things or block, they feel their shoulders shifting out the back. They can be very successfully treated with arthroscopic surgery. That's the preferred treatment, and they tend to do quite well. Some initial injuries will do okay with the rehab alone. Unfortunately, there's no way to brace posterior dislocations. We have bracing that we can use for anterior dislocators, often use those when people are returned to play, but we don't have anything that works for posterior dislocators, so often they will become a surgical problem. Slap tears. Slap tears can happen in throwers, like I said, with repetitive cocking and acceleration. I see them more often with falls on extended arms or running backs carrying the ball who get their elbows driven superiorly at the time of the hit, and they tear their labrum. They have persistent pain in the anterior aspect of their shoulder, most often with overhead activity. Something just doesn't feel right. There's something going on in there. And they can become surgical problems. They're difficult to diagnose in the sense that there are not really good physical tests for this. There's an O'Brien test where you have the patient bring their arm in front with their thumb extended anteriorly. You resist anterior movement of the arm. Then you have them reverse it into this position, and you resist. And if this creates pain, it's suspicious for a slap tear. The other one is a grind type test where you just take the humeral head and you move it around and see if you recreate pain. We will typically use an MRI arthrogram. These are difficult to image as well. It's kind of a dynamic lesion. We use the arthrogram to see if we can see under the labrum, but the labrum's kind of laying there where it's supposed to, and dye doesn't get in there, you may get a negative report. So clinically, if they remain symptomatic, we sometimes have to do an exam under anesthesia with the arthroscope and then repair it as indicated if it is actually torn. Just pictorial representation for slap. It's like a type 2 slap in the top where the labrum's been detached at 12 o'clock. Go in, diagnose, again make a raw bony bed, fix it with a arthroscopic anchor and suture to stabilize it. For labral injuries, they typically are going to be in a sling for 3 weeks to 6 weeks. They use range of motion, do their rehab. These folks always amaze me. Typically in 2 weeks to 4 weeks, they feel great. Younger athletes, I worry they're going to go out and do things they shouldn't do because they feel good. They don't have a lot of residual symptoms from the arthroscopic surgery. The restrictions for them are no heavy weightlifting for 4 months, avoid collision or contact sports for 6 months, pitching 6 to 12 months. That's shoulder dislocations. That's acute injuries in athletes. Any questions?
On those athletes that develop the Hill-Sachs lesions, how effectively can you go back in and graft or repair those?
In the massive Hill-Sachs, they may require bone grafting. Okay, it's difficult to treat. If you have a moderate Hill-Sachs, but you don't have the massive instability, if it's creating a lot of instability, you probably go to a lateral rejet. Okay, and just ignore the Hill-Sachs. Provide the stability by extending the glenoid. But there's a technique called remplissage, and you place a suture anchor within the Hill-Sachs lesion, and then you pass sutures through the capsule posteriorly, and you tie the sutures and you bring it down to fill the defect to try to reduce the engagement of the Hill-Sachs on the glenoid. Remplissage. For remplissage, I'd run concurrent with the stabilization of the shoulder because it'd probably be done at the same time as a anterior labral repair. Any other questions? Well, thanks for your attention. It's always an honor for me to be here.
All right, so we're going to do some more door prizes, so don't leave.
All right, everybody. Going to give away some more door prizes right now. Go ahead and last minute. It doesn't help to bend them, just so you know. Yeah, so our next speaker, is that correct? He's going to be an evidence-based practice talk. If you need to have your badge scanned so you'll get credit for it, just take your badge off and set it on the front of your table, and we'll be going by during the talk to scan the badge. We're going to wait till the talk starts, and we'll just go through quietly and scan them, okay? So that's if you're certified and you need that evidence-based credit. If you would rather turn that in as a Category A, if you're certified, don't get your badge scanned. You can't claim both. Can't claim both. So if you get your badge scanned, it's for an EBP, and that's what will be sent to the BOC, right? We have to send a report to the BOC. If you get your badge scanned, it's going to be sent that you are claiming that as an EBP. Does that make sense? Okay. Door prizes. Limited edition. Very few of these left. There's a prize in there. That's going to go to Sarah Gulick from Pace High School. We've got another anchor bag, little cooler bag. Sparky Flores, Stony Point High School. Back in the back there. Kind of want to save this for last. I don't know about the name of this product. Lube in a tube. Starter kit. It's not even the real thing. It's a starter kit. Lube in a tube. From Mueller, one of our vendors. Melba Corona. Melba. Is Melba here? There she is. $15 Whataburger gift card. Christopher Lay, Blanco ISD. Where's Chris? Back in the back. This is going to be a $25 Whataburger gift card from the brokerage store. Ben Garcia, Lyford ISD. Where's Ben? Back in the back there. This is going to be a Dolphin Watch cruise for 2 people. Dolphin Watch cruise for 2 people. Mike Brunson, PSJ Southwest. There you go. You better take your wife on that. I'm going to tell her you won that. He's taking Chad. Chipotle. Hopefully, maybe San Juanito will win this one. Joe Cruz, Eastside Memorial, my old stomping grounds. It was Johnston High School when I worked there. Chili's, what's up, man? This is a Chili's or On the Border macaroni grill for $25. Minette Bazan, Gruya High. Minette. There you go. It'll be Chili's because we don't have any of those other places down here. Rank 1 Sport, $25 Amazon card. Andrea Hernandez from Palmview High School. Where are they at? Not here? Going to be Katie McIntyre from Carroll High School. Nope. Okay. Balde Cantu, PSJ High. Where's he at? Oh, there he is over there. Okay. $25 to the Sea Ranch Restaurant. Brad Dixon, Del Rio. Where's Brad? You better go take your new assistants out to eat tonight. This will be 3 glasses of tea right there. Last but not least, $50 in cash. Stephanie Post, Pleasanton ISD. There she is back there. Stay tuned. We'll have more later.
And we will start at exactly 2:10, so we still have about 7 minutes. Remember, if you want your badge scanned, to make sure you put it at the edge of your table so we can scan that a lot easier.